Hi, everyone. Welcome to the MIT Press Live, a new virtual event series brought to you by the MIT Press. My name is Nicholas DeSabatino, and I'm the senior publicist here at the Press. I'm filling in for our regular host, Hannah Nyren. Today, we're speaking with Dr. Mikhail Sekaris, author of When Blood Breaks Down, Life Lessons from Leukemia, which we published this spring. In his winning endorsement of the book, Siddhartha Mukherjee, Pulitzer Prize-winning author of The Emperor of All Maladies, a biography of cancer, writes, "In this powerful and wonderfully written book that both educates and moves you, Sekaris writes with the authority and compassion that comes with decades of practice." Great to see you, Mikhail. How are you doing today?
I'm great, Nicholas. Thanks for having me.
Thank you so much. So as we get started, I wanted to first ask you, can you tell us a little bit about yourself?
Sure. Well, I'm director of the leukemia program at the Cleveland Clinic in Cleveland, Ohio. And as you mentioned, I'm here to talk about my book, When Blood Breaks Down, Life Lessons from Leukemia, which I was so fortunate to have published with the MIT Press. I was born in the biggest little state in the Union, Rhode Island, went to college and medical school in Philadelphia, and then completed my residency and fellowship in hematology and oncology in Boston. I'm actually the son of a reporter for the Providence Journal-Bulletin, which of course is based in Rhode Island, and I've always felt that writing was actually our family business. From the moment I met my first patient during my training, I've been fascinated with the interaction between that person and his or her healthcare provider, from the time of that person's diagnosis with a medical condition and the relationship that forms between them over time. I've even based some of my research on the communication between patient and doctor.
Thank you. Why did you write this book?
You know, Nicholas, I've always felt that medicine is actually based on storytelling. A patient tells a doctor or nurse the story of his or her illness, and the doctor or nurse passes that story on to each other, to colleagues and trainees, as they try to tell the story of how to eliminate disease. As with COVID-19, the story or tale of leukemia is one of a terrible invader, what I refer to as a malignant golem, that ignores the niceties of health in corrupting the body's normal machinery to wreak havoc. It's a tale of fantastic discoveries about the genetic basis of the golem, which lead to the drugs that hopefully will be its undoing. My personal inspiration, though, actually lies in the tales of the people diagnosed with cancer who were forced to make impossible choices about treatments that will affect their health and the fabric of their families, and how they do this with such grace and dignity. I was drawn to medicine by the stories and frankly, the chance to write one about these remarkable people.
Thank you so much for saying that. Can you give a layperson's definition of leukemia?
Yeah, so leukemia is a type of cancer. Cancer involves the uncontrolled growth of cells. These cells acquire a genetic abnormality that allows them to grow faster and quicker than any other cell around them. If this happens in the breast, a person gets a lump because that lump are the cancer cells outgrowing the other cells around them. If it happens in the lungs, a person gets a mass. If it happens in the bone marrow, somebody gets what we call a liquid tumor. So those cells grow and grow and grow and outgrow other cells around them in the bone marrow. But the bone marrow is what I refer to as a high rent district. It's a narrow space, it doesn't expand. So these cancerous cells fill up the bone marrow, and as they do, the normal bone marrow cells die out. That has enormous implications for a person because the bone marrow actually makes the cells that wind up in our bloodstream. It makes the red blood cells that bring oxygen to our tissues, and when those are low or anemic, it makes the white blood cells, that's our immune system that fights infections. And it makes the platelets that help stop bleeding. So leukemia fills up that bone marrow, and these leukemia cells aren't functional. It's as if they're kindergartners trying to perform the work in a factory. As
I
they
like
fill up
that.
the bone marrow, the normal cells in the bone marrow die, and a person doesn't have those cells in the bloodstream, those cells that they need to sustain life.
Thank you. Tell us specifically about When Blood Breaks Down.
So in When Blood Breaks Down, I tell the stories of 3 patients who arrive at the hospital actually within hours of each other, and the tales of their lives and of their leukemias. Each of them is told to get their affairs in order when a blood test returns that's drastically wrong. And this happens all the time to patients I first see. They're diagnosed in an emergency room. An emergency room physician tells them, you've got leukemia, you don't have many days left. And this person is then sent to our leukemia floor to try to take care of them. One of these people is Joan. She's a 48-year-old surgical nurse and mother from the rural town of Wooster, Ohio, which is about 45 minutes south of us in Cleveland. Another is David, who's a 68-year-old husband and father from a border town in Ohio near Pennsylvania. And I talk about Sarah, who's a 36-year-old woman who's diagnosed with leukemia while she's pregnant, which is really, really tricky. One randomly thought 24 hours earlier that she was catching a bad cold, and that's why she was tired during these surgical cases. One that he was getting older and slowing down, and another that she was exhausted from morning sickness. Each one has to make decisions, though, that no person should ever have to make in his or her lifetime. Decisions that affect their lives and the lives of those closest to them. The three patients portrayed in this book are actually composites of people I've cared for over the years. The conversations that I detail, the medical twists and turns, the aspects of their lives that precede and follow their diagnoses all actually occurred to people in my decades of practice. The discoveries that led to the treatment options for Joan, David, and Sarah, as well as the biologic basis of their cancers, are truly remarkable. A curative therapy that comes from a root discovered in China, experiments in dogs and beagles that lead to the modern miracle of bone marrow transplantation, the unflagging research efforts of one man on one drug in a rare disease that actually caused him to lose his job, but eventually leads to one of the greatest therapies ever developed for cancer. Are you kidding me? This is actually what happened that led to the treatments and the way we manage people who have leukemia. Equally remarkable is the research behind the causes of leukemia, how doctors and patients communicate with each other, and how we all deal with a death that may be imminent. Perhaps most remarkable, though, is the undaunted spirit, the utter humanity of my patients in the face of a treasonous bone marrow that has turned on them. And frankly, the chance to have even a glancing relationship with inspiring people like this, that's what really drew me into the field of cancer.
Oh, thank you for sharing that with us. Was there a moment when you knew you wanted to be a cancer doctor?
You know, it's funny, Nicholas. There are rare times in life when we can identify one moment that kind of changed our course. But for me, that actually happened. The first day of my internship, and I did my internship in residency at Mass General in Boston, I was assigned to the intensive care unit, and I'd never been in an intensive care unit before. And it's a really scary place if you've never been there before, particularly at a place like MGH, which is the referral hospital for much of New England. I walked through the doors and I was struck by the noises there, the beeps and boops of the machines, people talking loudly at the nurses' station, and just the utter devastation of humanity, of people lying in beds who were just at that critical pivot point between life and death, who were just absurdly sick. And it was that very first day when somebody came into the intensive care unit, a woman who was in her 30s, who had metastatic ovarian cancer. It was an awful diagnosis in a person at a preternaturally young age to have a diagnosis like this. And she was brought to the intensive care unit because the ovarian cancer had actually spread to her lungs, and her lungs were filling up with fluid. So she was brought there to be placed on a breathing machine. But after she got there, after she arrived, she actually changed her mind, and she said, you know what? I don't want a breathing machine. I've been fighting this for years. I'm done. She said, and she wanted to spend her final hours on this earth breathing air just like she's always breathed air, and not on an artificial respirator. So later that day, kind of in the late afternoon, her husband showed up with her two children who were aged 8 and 10. Oh my God, was that devastating. Whether you're a parent or not, seeing these kids brought in to really say goodbye to their mother. It was the last time they were going to see her. It just, destroyed all of us who were caring for her. And a lot of us either cried in private or just in public at just the utter humanity we were witnessing. Her husband, took the kids away to stay with a family friend. And then a couple of hours later, he showed up again with her best friend, and he was carrying a CVS bag full of something. I couldn't quite see what it was. But as I'm caring for patients all night long, I kept walking by her room, and saw her husband or her best friend holding up a clipboard. She kept writing and writing and writing. And I was completely confused and actually turned to my senior resident, who was like my lifeline for the night, my first night of internship. I barely even knew how to go to the bathroom anymore, right? I just had no clue what I was doing. So I turned to him and said, what's going on in that room? And he said, oh, she's writing cards. I said, cards? And I had a pocket full of these, like, 3x5 cards that I kept notes on. I said, was it one of these types of cards? And he said, no, it's not that type of card at all. It's birthday cards, holiday cards. And what she had decided to do was, during her last night on Earth, she wanted to write cards to her children for the next decade worth of life events that she would be missing. So she was writing birthday cards to them for every birthday they would have, bar and bat mitzvah cards, holiday cards, so she could be part of their lives in at least some way. And I really always felt like she lived out the last years of her life during that one night when she was filling out those cards. And sure enough, as morning came and the sun rose over the Charles River nearby, a nurse came to me and to my senior resident to tell us that she had died. And I thought to myself, you know what, that's the sort of person I want to know and I want to spend the rest of my life with, somebody who makes those sorts of decisions and does what she did on behalf of her family.
Wow, that's an incredible story. Thank you so much for sharing that with us. Would you be interested and willing to read a section from the book for us?
I'd love to, if you don't mind.
Yes, please.
Let me try to set up a little bit what the section I'd like to read. This is about David, who's the gentleman who's 68 years old. I talk in this section a little bit about his wife and about his children. And David had to face a hard choice when he was first diagnosed. He actually wasn't sure he wanted to get treated, but his kids were so desperate not to lose their father, they convinced him to take therapy. And we often see this sort of conflict within families about people who have different goals of what they want. And, being a good dad, he did what his kids wanted. And he did that a couple of times before he finally decided that, he was done taking therapy anymore when the leukemia kept coming back over and over again. And I talk a little bit in this section about my hematology oncology fellow, Rachel, who's still in training. And but she got really upset at how his kids pushed him to continue to take therapy, even though it wasn't something that he wanted. And eventually she came to terms with this also and made peace, I think, both with herself and with his children, particularly his son, Eric, who was really pushing him. So this section is about him kind of making a final decision about his care. So I knocked on the door of his exam room and entered. Just as I was about to shut it, I felt a push on it from behind as Rachel squeezed in behind me. Sorry, she whispered as she shut the door behind us. David sat in a wheelchair by the desk. The room was packed, just as it had been the day we broke the news to the whole family that his leukemia had never gone away. He was wearing a Cleveland Indians cap and sweatshirt. So was Betty, his wife. Opening day for the team was just a week away, and a bunch of my patients were similarly outfitted, as if through this act of sartorial intimidation, they could bully winter into submission and clear the way for spring to finally arrive in Cleveland. The weather in Northeast Ohio has a reputation for shrugging its shoulders at these vainglorious attempts. On opening day in April of 2007, it dumped enough snow to cancel a game against the Seattle Mariners one pitch before the game became official. In protest, a fan ran onto the field, threw himself on the ground, and made a snow angel in the right center field. With typical Cleveland self-effacing humor, the stadium's PA system played Bing Crosby's White Christmas during a second inning delay. The cap looked 2 sizes too big for David's head. He had lost weight, and as his tissue had wasted, the bones around his eyes became more prominent. He still had some of his tan from a recent trip he took to Florida with his family, and the darker color belied the degree of anemia he had. Betty looked tired, more resigned though than sad. His daughter Susan had taken her usual spot sitting on the exam table, and for reasons I'll never be able to explain regarding the haphazard migration patterns of chairs in the hospital, we were blessed with an additional chair for his son Eric. He sat across from his parents and along with Susan greeted us with a smile. As I moved to sit next to David, I saw Rachel mouth to Eric, "How are you?" and watched him give her the thumbs up sign. "It's getting to be a lot coming in here all the time," David said, his voice not as resonant as it once was. "On me and on all of them." Susan rolled her eyes. "Daddy, it's no trouble for us at all. It's nice we get some time alone with you." David smiled at how she soft pedaled the disruption to her life, to all of their lives. They had raised her well. He continued, "I'm thinking it might be time we get that hospice involved and stop these transfusions." "We've worn out our welcome, haven't we?" I asked. He smiled again, wanly. "Besides, I don't want to miss opening day next week because I'm sitting in one of your infusion chairs." "That would be my choice too," I told him. Could David make it long enough to see opening day? I've long been convinced that, at least to some extent, and within the boundaries imposed by the aggressiveness of their cancers, my patients die only when they're good and ready to. For many, that time occurs after they've achieved a specific goal. Perhaps it's the birth of a grandchild or that grandchild's college graduation. Maybe it's seeing the long-lost sibling a patient has been feuding with for years. Parents always wait to say goodbye to their children. I've seen patients, even those moribund and comatose, linger for days until a daughter or son from overseas arrives. One patient, a man in his late 60s who had multiple cancers, told me his goal was to walk his granddaughter down the aisle at her wedding. He and his wife had raised her while their daughter, who had gotten pregnant in her teens and then became addicted to drugs, struggled to get her life back in order. After surviving colon cancer years earlier, he developed lung cancer. Prior to treating that cancer, the lung cancer specialist referred him to me when he noticed the patient had abnormal blood counts. A bone marrow biopsy revealed both acute leukemia and another bone marrow cancer, multiple myeloma. 3 cancers at the same time, 4 in total, but you'd never know it from his attitude. Determined, positive, and uncompromising. None of these cancers would keep him from that wedding. The chemotherapy knocked his blood counts down, but didn't do much to kill the leukemia. The lung cancer spread to his brain, leaving him partially paralyzed. We treated that well enough with steroids so he could walk again. You should have heard the gasp from everyone in the church when he came through those doors with our granddaughter, his wife told me. No one thought he would be there, but I did.
Thank you. That's a really powerful, beautiful section. I want to switch gears here just briefly and bring up, current events. How has the COVID-19 pandemic affected cancer diagnoses and treatments?
Yeah, it's a great question, Nicholas. I recently wrote a piece for the New York Times where I talk about this a bit. Interestingly, our patients who already have cancer diagnoses have continued on their therapy because frankly, they have to. Cancer is a diagnosis that's arguably scarier than COVID-19. And we can't let the cancer get the better of them by delaying those treatments. So they have continued on. What's been a little bit frightening, though, is that during April and May in our cancer center, we've seen a drop in new cancer referrals of over 40%, and that's something that's occurred actually nationwide. One report from an electronic medical record provider actually showed a drop of about 90% in cancer screening. And that's because these folks aren't going to their primary care doctors to have symptoms checked out and aren't going for their regular mammograms, pap smears, colonoscopies, the tests that diagnose cancer. So we're a little worried that we're going to see a bit of an uptick in cancer diagnoses. And what we're hoping is that we won't see any kind of increase in stage of these cancers because of the delay. I'm happy to say that our cancer center and others have worked really, really hard to ensure that everyone who comes in here, either for treatment or for a new consultation for a new diagnosis, it's a safe place. And we're screening everyone at the door for COVID-19. We're taking their temperatures. We're making sure that our patients are going to be safe when they come to our cancer center.
Thank you. We want to also just thank you for all you're doing and every healthcare professional out there for what they're doing to combat COVID-19. I want to open up our discussion today to questions. I'm going to type into the chat section. If you're not familiar with how to use the Q&A chat section right now, I'm including some information right there. And while we wait for a few Q&As to start coming in, I want to ask you a little bit more about the writing process for this and how long it took you and how you were able to do it on top of your already crazy busy schedule and being a parent and everything else going on in the world.
I, Nicholas, honestly, I think that there's a kind of a community of doctor writers, and at first we hesitate to call ourselves a writer, right? You always worry about imposter syndrome, I think, in a lot of professions. And it's really true in medicine, right? You reach certain stages in life and you're almost hesitant to call yourself either an expert in a certain disease or a scientist or a writer. And at a certain point, I realized that for me, and I'm sure you've heard this from other writers, writing is breathing. It's how we process the deluge of humanity that we see every day. I think medicine it's a privilege to practice because we see a cross section of humanity and we hear stories that very few are privy to. And people invite us into their lives at these critical moments when they're facing literally life and death decisions. It's not an exaggeration. And we may be an unwelcome guest. No one wants to invite a cancer specialist in to talk about his or her cancer, but we're a guest all the same. And it's hard on those of us who provide care to people with cancer or serious diagnoses, just as it's hard on people having those diagnoses. So writing is a way of processing for me. And writing this book, I think there's no, secretive method to it. I travel a lot to give talks, and planes have become my office, and that's probably where I do most of my writing.
Thank you. We have our first question in. How does the treatment and survival rate of COVID compare to other types of cancers?
Of COVID?
Of COVID-19, yes.
So I'm going to try to clarify the question a little bit. So COVID-19, of course, is not a cancer.
Yes, sorry.
So when people have COVID-19, I've had to do a lot of reading on this because I feel as if I need to be updated on this on behalf of my patients, even though I'm not an infectious disease specialist. It has a much higher infectivity rate than something like the flu. So it passes easier and people get sicker from it. So you can say that the chance of getting seriously ill or dying from the flu is going to be somewhere around 0.1%. For COVID, it's going to be 1 to 3%. So it's a higher rate. And particularly in my patients, the likelihood that they're going to die from COVID is 3 to 5 times what it is for other cancer patients, never mind the rest of the population. So I have long talks with my patients about remaining on protections, on precautions, even as states are opening up. My patients don't seem to be more susceptible to getting COVID-19, but if they get it, they are more susceptible to getting very, very sick because they essentially have cancers of the immune system. They can't fight off the infection as well as other people.
Yeah. We have a comment question from Joanna who says, truly great book. Relating to David who did not respond to the induction therapy, what is the best option that you can offer nowadays in your clinic, having the quality of life in mind?
Yeah, it's a great question. So somebody who's older, and we actually have just published guidelines on treating older adults with acute leukemia through the American Society of Hematology. They're about to come out online any day now that kind of give guidance to this and really kind of look at it from a patient's perspective, not a doctor's perspective about the decisions people have to make. One of the critical decisions at first is whether to take aggressive inpatient chemotherapy or to take more of an outpatient regimen. Aggressive inpatient chemotherapy raises the chance of going into remission, but also raises the chance of dying from the therapy itself. So one of the first things I do when I sit down with a patient is try to figure out what that person's goals of care are. What is that person living for? And what does that person value in the next few weeks? Is that person willing to sacrifice being at home with family in a comfortable environment to be treated in the hospital? Or is that person not willing to sacrifice that? There was recently a presentation at the European Hematology Association that looks at a combination of drugs that's less aggressive, that actually shows a survival advantage to what we've been using traditionally for less aggressive therapies. The question in our minds is it as good as that aggressive therapy, and can we avoid the hospital altogether? So we've got new stuff coming out all the time. We've had 10 drug approvals in a 2 to 3 year period at the FDA over the last 3 years, which has been really, really cool. And for the first time, the opportunity to target some of these genetic abnormalities that have caused the leukemia to arise.
Thank you. We have a question from Kess, who's asking, we live at a time when many survive cancer. I often think about it, what costs though? I've had stem cell transplant and 4 years on, I've had a poor quality of life. Is there anything on the horizon that can help people like me regain my quality of life?
Right. It's a super question, and I'm sorry that you've had a poor quality of life. And you're right, sometimes the trade-off is a very aggressive therapy like a stem cell transplant, but then the theory behind it is you're transplanting somebody else's immune system into your body to attack and get rid of the leukemia. Well, that's wonderful if it happens, but if that immune system then attacks some of the other organs or tissues in the body, it can be tough to live with. And people can get everything from, graft versus host disease, where they get bad rashes, or can get, terrible GI effects, all the way to having trouble breathing from some of the effects of that transplanted immune system, and infections that a person can get that comes along with it. I think increasingly, with less intensive transplant regimens, with better immunosuppression, there's a drug that was just approved to help treat graft versus host disease that seems to work really, really well and is pretty well tolerated, called ruxolitinib. I think people have the opportunities to live better quality of life after the transplant, but you're right, sometimes it's a trade-off, and you don't necessarily know what you're getting into.
Great. Our next question comes from Victoria, who is an educator and radiation therapist. Why do so many physicians offer hospice to their patients so late in the course of the disease, when the patient may experience a better quality of life foregoing treatment?
I adore this question, and it's one of the drums that we beat also. And actually in these new guidelines, we have a section that specifically addresses hospice and the reason for this. And there are a couple of reasons for this. The first is most hospices won't support a patient getting blood and platelet transfusions. So if you have something like leukemia and you're at the end of life, you're dependent on blood and platelet transfusions to live. And particularly blood transfusions improve your quality of life. It makes you feel better. But blood and platelet transfusions are expensive, and hospices are only reimbursed by Medicare at a very small amount per day. So let's say that you go into a treatment center for a blood transfusion. The cost of the blood, the infusion chair, the facility charges, the pre-medications, the visit with a nurse or doctor, all of that, you add all of that up and you're probably talking about $1,000, whereas Medicare is reimbursing hospice at a rate that's probably closer to $100. So one of the reasons, it's an awful thing to say, but it's economic. Hospices won't allow blood and platelet transfusions. And that's something we addressed in our guidelines, where we said very clearly, these should be standard hospice treatments for people with leukemia. The second reason, and this is a much more nuanced one, is that, and this happens with David actually, and why I wrote the story this way, people will agree to another treatment in the hopes that it'll work and they'll go into a remission. And then they'll often agree on another treatment, and you get on this kind of hamster wheel of treatments for the treatment of cancer. And often it takes a seminal event like being admitted to the hospital where a patient or a doctor may realize, wait a second, what are we doing? This isn't helping. This is a terrible existence. And a person then changes gears right then and there. So that's one reason I think why leukemia patients are often hospitalized in the last 30 days of life, which studies have shown. It's not for nefarious reasons. It's because sometimes it's that hospitalization that causes somebody to pause and say, I don't want this anymore. I want to switch over to hospice. And it's also why hospice is initiated so late, because a person has agreed to another therapy, and it's only when they have that seminal event when they say, I'm ready for hospice. And often that hospice is initiated, unfortunately, within the last 30 days, when that person really would have benefited from it for months.
Wow, That was a great question. Thank you, Victoria, AKA my mom. Our next question is, Mikhail, why did you choose this narrative format for your book? What do you hope that people will take away from it?
I love that question also. And Mrs. D. Sabatino, you raised him well. Um, uh, you know, I looked at it from it's funny, the initial kind of thoughts on this and kind of my pitch to a publisher was focused more on a memoir from my perspective. And then I realized, I was like, that's completely wrong. It's not about me, it's about my patients. And I think as a writer, our job is to step away from our characters and let them take the spotlight. So for me, this is, and I reflected on it and realized it's what's always drawn me into cancer care. It's all about my patients. So I stepped aside and really wanted patients to be the focal point for this. And I thought it would be, I don't know, I felt like kind of from a creative license to have composite characters where I could tell the stories of a lot of patients in these three folks I focused on.
Great. And that question was, I believe, from Jane Williams. And she has another question that we're going to ask right now. Is cancer screening rarer among poorer groups because of healthcare costs?
Yeah, boy, is that a super question. Yeah, the answer is unfortunately yes. And it's rarer for probably a bunch of reasons. It's really complicated. The first is availability of screening centers. A second is, and I hear this from patients all the time, listen, I practice in Cleveland Clinic. We're an enormous place. I feel as if my first job during the first few minutes of meeting somebody is trying to deconstruct Cleveland Clinic and say, wait, it's not this enormous hospital that's so intimidating. It's just me and you. And we're going to talk about your cancer and make it much more personal. So it's intimidating coming to a big hospital for cancer screening. Some of it may be costs. So people who don't have insurance may not feel as if they have the means to get screened. They may not have the opportunity to get screened. Some of it are also biases about healthcare systems. We all live with the horrible, horrible story of the Tuskegee experiments, where African Americans who had syphilis were told they were getting treated for their syphilis, when in fact they never were, and instead were followed as part of a medical experiment. What a horrible thing. That has not died, and I've met with community groups in trying to figure out how we can meet the needs of our population in Greater Cleveland. And they still bring up the Tuskegee experiment and how they don't trust healthcare systems. So it's multifactorial why this happens and why there are delays in cancer diagnoses for people of different sociodemographic backgrounds.
Wow, thank you for that. I want to next I wanted to ask you a question. So you mentioned that, you've written a lot about COVID-19 and, cancer treatments. I want to refer to a piece you wrote for the New York Times back in April called Coronavirus and the Cancer Patient. And I just wanted to read one small section and then have you comment on that a little bit, if that's okay.
Sure.
I miss the intimacy and the innocence of my visits with patients. The coronavirus pandemic and the impending tsunami of how it will sicken us has fundamentally altered how we think about healthcare. I recall fondly the carefree days of just a few weeks ago when I casually scheduled one patient with leukemia for a follow-up visit to assess her response to therapy and need for blood. She lived a couple of hours away east of Cleveland and was being treated by a doctor close to her home. She asked me to monitor her progress too, and we saw each other every couple of months. As part of the routine of caring for my cancer patients back in January, I had checked a couple of boxes on her electronic medical record for an appointment in 8 weeks, along with the appropriate labs to be drawn and for a possible blood transfusion. But the balance of risks and benefits for all of my patient interactions has now changed. Wow, that's powerful. Can you talk a little bit about that piece for us?
Sure. It's funny, when we're in medical school, we're often given these communication courses, right? And the communication courses are so to teach doctors how to talk to patients, which seems kind of curious. It's as if we had no idea how to talk to people before medical school. But what it does is it's almost, it does the opposite. This has always been my theory. By having a communication course, it almost teaches us that we have to talk and interact with patients in a different way than we've always talked and interacted with them. I wrote a piece with a close friend of mine named Tim Gilligan, where we talk about this phenomenon, how, if you're walking down the street and you see a neighbor fall down the stairs, if you're in healthcare, you run over and say, on a scale of 1 to 10, how would you rate your pain? Whereas if it's just us interacting with somebody we know, we would run over and go, oh my God, are you okay? Can I help you in any way? Let me help you up. So I've always been more casual in my interactions with my patients. I'll, tell stories. I'll talk about my family, and I have a lot of, contact with them. I would say probably half my patients and I hug at the end of an interaction.
That's
So
lovely.
this virtual world we live in is odd. We can't, the touching is gone. The kind of nuances of how we interact with each other. If it's virtually, there's this screen that's blocking us, and you never know whether you should be staring at the cameras or staring at your patient or staring at this awful image of yourself, right? And if it's in person, we now have masks on, so we can't see, just the first blush of a smile or the crinkle of the eyes. We can't read that, the subtleties of a person's reaction to what we're saying, and then respond to that. I think that's been a huge hit both for my patients and for me. And again, as centers are opening up again, we're going to be living with COVID for the next 18, 24 months. This is going to be part of our new reality. So our center has shifted to deal with this. Other centers have also, so it's a safe place, and we're bringing our patients back. And I have to say, I've really missed it.
Yeah. It's a crazy new world. We have a few other questions coming in. This next one is from Sophie. In rare blood cancers, how can we encourage general hematologists to refer patients for additional opinions? There is a stigma about asking for a second opinion. All patients we know are concerned with upsetting their hematologist if they ask to see someone else. And this is the MDS UK Patient Support Group.
Oh yeah, I see them on Twitter. So thanks for the question. It's a great one. My philosophy has always been a doctor who gets upset about a second opinion is the wrong doctor, and you need to switch doctors. If I or one of my family members had a rare diagnosis, you bet we'd seek a second opinion. And I never take offense when my patients want to seek a second opinion. I prefer they do. And I think somebody who's, I worry that it's healthcare providers who are more defensive about the recommendations they are making and are less sure of them who are going to take offense at something like that. At the end of the day, we're our own best advocates, and it can almost be a litmus test for whether a healthcare provider is the right person for you to say, and it doesn't have to be in an intimidating way, to say, I'm thinking about seeking a second opinion, just because it would make me feel better, and I know that what I have is rare. Are you okay with that? And to judge what their reaction is to it. But absolutely, you owe it to yourself if you have a rare diagnosis to get somebody else's take on what to do.
Yeah, thank you for answering that question. That was a good question. Next one we have is from Ollie. Why do you think it is possible that people seem to be more scared of cancer than other health problems?
One of my, actually my best friend once kind of made the joke when I told him that I wanted to specialize in leukemia. He said, leukemia needs a better press agent, maybe somebody like Nicholas. Because cancer has it's very, very scary. It wasn't that long ago, even a generation or two, my grandmother would never say the word cancer above a whisper for fear that she somehow, by saying it out loud, she would invoke it. When I wrote my first book, she quickly, being a good Jewish grandson, I gave it to my grandmother, and she quickly took it and hid it on her bookshelf so no one would see the word cancer in the title. So it isn't that long ago that cancer had this horrible stigma, and frankly, the movies haven't made it any better. I'll sometimes joke with my patients that as we're talking about cancer, that we're not all going to kneel by their bed with the lights dimmed and a bunch of candles lit. Like, it's not how it works. We're going to talk honestly and openly about it and answer their questions. And if we don't know the answers, to go and find those answers and treat them as human beings. One of one of my patients, she had a great sense of humor, and she and I would tease each other all the time. And we were bringing her into clinic right around the holidays. And I said to her, I'm sorry, we're dragging you in here on Christmas Eve. And she kind of looked to the ground and said, she's like, I hate to say this, but I actually prefer being here than at home, because at home they treat me like I'm some fragile piece of glass that's about to break. At least here you treat me like I've always been treated.
Wow.
So there is this stigma about it, and why people are more scared about cancer than about other diseases. But there's a wide spectrum of seriousness in cancer, and frankly, there are some cancers we don't treat at all. We just watch them for years.
We have another COVID-19 related question, a little more general, but what do you wish you'd known at the start of the pandemic that you know now?
What a brilliant question.
Yes.
I want somebody to ask me that question a year from now also, because the answer will be different. I wish at the very beginning we had all taken the wearing masks thing more seriously.
Yeah.
And it was confusing because, there aren't enough N95 masks to go around. N95 prevent me from giving the mask, the COVID-19 to you, and prevent me from getting COVID-19 from you. So we thought the N95s were the be all and end all, and there wasn't as much sense to wearing the other masks, which just prevent me from giving it to you if I'm wearing the mask. But if we had all been wearing those masks at the very beginning, we would have a much different picture of the fallout from COVID-19 than we do right now. That's the main thing I wish I'd known at the beginning. Those of us in healthcare knew that hydroxychloroquine was baloney and dangerous. We knew that about those drugs. So given that we don't have a great treatment for this right now, we do have remdesivir, which works okay. One study has shown it decreases the length of hospital stay, but there still aren't any survival data around it. The other drugs really don't work that great. So the biggest dent we can make in this is prevention. That's honestly the one thing I wish I had known better back then.
That's a good question. Thank you for your answer. Your next question comes from a very familiar, friendly voice, one Mr. Robert Pryor, who your executive editor. Can you tell us about your next book with the MIT Press?
Oh God. So the answer to this question is filling me with dread, because the good Mr. Pryor now has the first section of this book. And I'm waiting on pins and needles of his opinion of it. The next book, I'm actually going to talk about the FDA and how we get drugs approved in the United States. And I come from this from the perspective of somebody who actually served on the Oncologic Drugs Advisory Committee at the FDA. I served on it and for 5 years and was chair of it for 2 years. And this is the committee, when you read in the newspaper, an FDA committee today has voted to approve this drug for cancer. That was our committee. So I look at it from an inside the Beltway perspective of having sat on that committee and had to try to judge whether the relative balance of safety and efficacy of a drug is worth it, to say yes or to say no. And I would kind of half joke, half not joke that when I would come home from one of these meetings, I would tell my family either that we had voted to make another drug available to cancer patients who were desperate from it, or we had voted to safeguard the health of the public. And the things that go into a drug eventually making it through the FDA are so complicated, and it has, at the end of the day, the relative balance of safety and efficacy is part of it, but so is activism, advocacy, the political wins at a certain time, how trials are constructed, and that gets into the fascinating background of how you write a clinical trial and how you demonstrate that a drug is actually better than another drug that's out there. So that kind of got me into this, and something I've always wanted to talk about and write about. So thank you.
Your editor says, thank you. Your editor says the first chapter is very good. So No
Thank
pins and needles. Our next question, thank you, is do you find that there is a stigma about the benefits of the support that hospices can provide for cancer patients in the community? By benefits, I mean support from occupational therapists and physiotherapists and nurses.
Boy, another fabulous question. Hospice needs a better press agent also, Nicholas. You got to get on that one too. It's tough because you hear hospice and you think, okay, some of my patients have said, I don't want you to give up on me. Oh my God, hospice is the opposite. Hospice means we're dedicated to you at such a deep level. We have people coming into your house to help out. It means that I can write prescriptions for medicines that you don't have to come into an infusion center for anymore. That the focus is really on quality of life and on living a great life for the number of days you have left. But again, we're dealing with decades, generations of stigma around terms like this. And I've had instances when I've referred a patient to hospice, and as tricky as that is with the diseases that I treat, often it is kind of a last minute thing. We get into the hospice game too late. I've referred patients to hospice where 6 months later they come back to my clinic and say, I'm still alive, can I come off hospice now? Right? That's a wonderful outcome. So that can happen also. It doesn't mean that when we give the nod to hospice to come and help, that all of a sudden everything's gone and that we're only expecting you to live for hours. It's actually the opposite. We're hoping you're going to live for months and live well for months.
Thank you. Our next question is, have you found that there has been less compassionate use programs for hematology drugs since COVID or more?
It's another great question. So compassionate use of COVID-related drugs has improved, and in fact, the FDA gave an emergency approval to hydroxychloroquine, probably because of political pressures that they just withdrew. So for COVID-related drugs, there's been more compassionate use. For cancer-related drugs, there's probably been less if you're looking at the numbers, but I think that's more because there haven't been as many people who've been going to cancer centers, and there hasn't been as much support at cancer centers as there was pre-COVID. We have a lot of people who are, for example, working from home, and we had to figure out how they could do that. I think we're at a place now where things should return to the way they were, and people can get just as much compassionate use cancer drugs as they could before all this started.
Great. This same question also comes with a follow-up question. Can we clone you?
You'd have to get permission from my wife, and I'm not sure she would approve of having two of me because there's already one of me who doesn't do enough around the house.
Oh, well, I think, yeah, well. That's great. Hold on one second. Okay. So I put in some more information about how you can find out information about When Blood Breaks Down in the chat. How you can find different ways of purchasing it, especially at an independent bookstore. We want everyone to support independent bookstores at this very stressful time. We have a link to the book on our website here, and different ways you can get your books, your hands on the books, either an audio or ebook version as well. What else? One new message. Yep. I wanted to. All right, so your book has gotten some really lovely praise, and this isn't a question, but more some bragging. Your book has been praised by medical writers Eric Topol, Dr. Daniel Olfrey. We already mentioned Siddhartha Mukherjee, Jay Baruch. We've gotten wonderful reviews of your book on the Washington Post, Library Journal, Kirkus Reviews, Publishers Weekly. And more to come.
Great, thank you.
Let's see what we have. Another question coming up. If anyone else has any other questions they'd like to put in the chat, please feel free. We'll be wrapping up very shortly. Can you talk a little bit about what it's like at the Cleveland Clinic right now? Just the general vibe and atmosphere in your area, and then just, what it's like.
Yeah, sure. So we've all been focused on COVID. and I've told people that I trained during a generation when we just focused completely on what we called evidence-based medicine. We're only going to practice medicine that's based on clinical trials that have been performed and demonstration that a drug is worthwhile for our patients, right? We're going to base our practice on the evidence. The generation of docs before us prided themselves on being superheroes at the bedside and making that kind of last minute decision that's going to save somebody's life, right? That's what we've all seen in the older movies and TV shows. With COVID, we were thrust into our forebears' generation. We were faced with a virus that we didn't know what to do with. We don't have evidence on it, right? We're doing things in real time. So a lot of the things that we've done here is to safeguard the safety of our patients, continue their cancer treatment throughout this, and also learn how to treat both leukemia and COVID in the hospital. So we have a COVID rule-out unit at Cleveland Clinic. We were the first floor to also identify specific COVID beds for patients who were being ruled out for COVID or who had COVID, who could also receive treatment for their leukemia on the same floor. That takes an enormous amount of operational innovation to figure out how nurses and advanced practice providers and doctors are going to take care of these patients at the same time they're going to take care of patients who aren't COVID positive. But I'm happy to say we figured this out. We're now, and our numbers in the Cleveland Clinic Enterprise have actually thankfully been not that bad. We never saw a surge that exceeded the number of intensive care unit beds that we had. And our numbers this past week have actually been lower, which really gives me a lot of hope for where things are headed. But we're also realistic about this. We're going to have COVID in our lives for the next 18 to 24 months. Yeah. So we're now shifting to take care of COVID patients side by side with patients who don't have COVID, because that's the reality of where things are going.
Let me see, one other question. This is kind of a question more just like, how do you have these wonderful skills of being an excellent doctor and writing an excellent book?
Oh, gee, thanks for the softball. My parents, honestly, were both English majors. I'm the only doctor in my family. And I used to, when I was in medical school, I would kind of, put on my white coat armor and start to use these big words I had just learned. And my parents would dress me down on phone calls about doing that. And they would kind of snap at me and say, we don't know what those words mean. And if we don't know what they mean, your patients don't know what they mean. So you need to speak simply. And I realized that what I was doing was overcompensating, right? Some of the medical terminology we have it's like an intellectual muscle car, right? We're using it because people who use overly complex words, I think, are hiding behind them. So I've tried to work hard to speak to my patients the same way I speak to my colleagues, which is not, going down that route of using overly complex terminology.
Great, thank you so much. Last question is, what is one key takeaway that readers can get from your book, When Blood Breaks Down? Or more than one?
No. It's okay. Leukemia is really could be any serious diagnosis, any serious illness. And one of the things I've admired in my patients is how we throw this diagnosis with them. And leukemia is one where, they only have 48 hours to first hear the word and then make a decision about treatment. That's how quickly we rush them to a leukemia specialty unit, do all of our testing, try to educate and get started, because particularly for people who are younger with acute leukemia, every day matters. Every day, from the time we make a diagnosis to the time we start therapy, every day that passes, my patients don't live as long. So we really rush into it, and it's unfair of us. But these folks are incredibly inspirational for being able to handle that and make a decision and then adjust to their new reality. And one of the things I've learned from my patients is the value of kind of taking a moment, stopping, and getting time with your friends and family to talk through your goals and focusing on those goals to then define what decisions you have to make. If there's one message I could take out of this, Nicholas, it would be when faced with something that's a serious medical diagnosis, stop, talk to your friends and family, define your goals, and then make a decision.
That's really powerful. Thank you. We actually just got one other additional question, which I think we have time for one more. Is blood cancer talked about in the general population? I'm hoping your book and some of the articles in the general press will improve this. More articles seem to be seen in the US than the UK, for example. This is again from MDS UK.
Yeah, when I talk to folks who are involved with media relations in the hospital or in medical organizations, they always say what reporters are interested in are topics that involve new technology, things that affect older adults, or cancers that affect women. It's interesting, right? That's kind of what, at least media experts say, that's what the press is interested in. So that's probably why we see more topics about those issues than we do about something that's a blood cancer. And unfortunately, it takes a famous person to get it into the news, like Robin Roberts of Good Morning America, or who had myelodysplastic syndrome, or Nora Ephron, who wrote, When Harry Met Sally, who had acute leukemia. Unfortunately, it takes a sports star like Kareem Abdul-Jabbar, who has chronic myeloid leukemia, or it takes a television personality to get it out there. So it's an unfortunate reality that we all deal with, and all we can do is keep highlighting the special circumstances and special needs of people with blood and bone marrow cancers to get the word out.
Great, thank you. Again, as we said in the chat, if you want to support independent bookstores or find an ebook or audio version of the book, we have a list of a few different ways you can get your hands on When Blood Breaks Down. We encourage you to get your copy today. Dr. Mikhail Sekaras, thank you so much for your time today. Thank you for all the hard work you're doing out there, you and other healthcare professionals. It's a privilege for us to publish this beautiful book. We're so grateful. Thank you for taking the time to talk with us today at the MIT Press Live.
Gee whiz, thank you so much, Nicholas, to you and everyone at MIT Press and everyone who tuned in today. It's been a real pleasure and a privilege.
Great. All right, well, we will see you all next week. Thank you again, everyone, so much for your time today. We hope you pick up a copy of When Blood Breaks Down. Thank you, everyone.